right. Hello there, everyone. We are so excited to welcome you to this month's Canna Talk. My name is Genesis Emery, and I'm the Director of Marketing and Public Relations for the Society of Cannabis Clinicians. On behalf of the SEC, we could not be more excited to see you guys today and, of course, bring you the latest educational insight on this month's featured course, which is Cannabis in Geriatrics and Assisted Living, led by our remarkable course expert and world-renowned medical cannabis doctor, Dr. Mikhail Kogan. We are so happy today to be able to share his phenomenal insight and research on cannabis and geriatrics and assisted living. Before we get started, let's go over a few brief housekeeping rules. Please kindly make sure that you kindly mute yourselves at all times. In the event that you do need to step away or take a break, please make sure you turn off your video so that we don't see what you don't want us to see you doing. Also, there'll be plenty of time at the end for questions, so be sure to submit your questions in the chat box throughout the show, and we will ask Dr. Kogan during the Q&A session. By the way, in case you guys did not know, you can now purchase Dr. Kogan's course on cannabis and geriatrics and assisted living directly from the SEC's course catalog on our website. What's even better is that this course is not only the featured course of the month, but it's also discounted right now. It's 20% off to SEC members and 15% off for non-members. The discount code is Dr. Kogan 15. Purchase this clinical training course today so that you guys can take advantage of it while the sale is valid. Other than that, please sit back, relax, enjoy the show, and stay tuned for our exciting Canna Talk segment featuring Dr. Frye and Wilson King. Without further ado, I'm pleased to introduce you to the SEC's Vice President and also one of our phenomenal board members, Dr. Patricia Frye and Dr. Janester Wilson King. Thank you guys so much.
Well, welcome everyone. I'd like to take the opportunity to welcome you to our Canna Talk. And today I have the pleasure of introducing Dr. Kogan. Mikhail Kogan is a leader in the newly established field of integrative geriatrics. He's the chief editor of the first definitive textbook on the field entitled Integrative Geriatric Medicine, which is published by Oxford University Press as part of Andrew Weil Integrative Medicine Library series. And he is a frequent speaker at a variety of international conferences on the topics of integrative medicine, geriatrics, healthy aging, as well as medical cannabis. While Dr. Kogan's main medical cannabis expertise is in treating older patients and palliating symptoms at end of life, he also treats a wide range of internal medicine problems, from chronic GI problems to cancers, where use of medical cannabis may be very beneficial. In 2020, Dr. Kogan partnered with Joan Liebman Smith and Penguin Random Publishing House to write Medical Marijuana, a book for the general public, which is scheduled to go on sale in October of this year. Dr. Kogan currently serves as medical director of the GW Center for Integrative Medicine. He's associate professor of medicine in the Division of Geriatric and Palliative Care and is associate director of the Geriatrics and Integrative Medicine Fellowship Programs and director of Integrative Medicine Track Programs at the George Washington University School of Medicine. Dr. Kogan is also the founder and executive director of AIM Health Institute, a 501c3 nonprofit organization in the Washington, D.C. metropolitan area that provides integrative medicine services to low-income and terminally ill patients, regardless of their ability to pay. It is my distinct pleasure to introduce and welcome my friend and DMV colleague, Dr. Mikhail Kogan.
All right. Thank you. And also, I'd like to say we are honored that you are here for this lunch hour talk show. I'm going to ask the first question. Can you share how cannabis has impacted your geriatric practice positively, and elaborate on some of the biggest challenges you've experienced using cannabis in your geriatric practice?
Oh, we'll talk about challenges first. So keep it positive towards the later.
We want you to be bold and then say what you
That's
feel.
right. Yeah. Well, just in case we don't, anybody from DC government joins later, then I don't get in any legal trouble with anybody. So I think the largest problem, we serve a lot of frail older adults, 80 plus, and I will tell you the DC government, but actually all three states, since I'm licensed in DC, Virginia, and Maryland, really the process of getting the cards is just disaster. And not only is it just really difficult if somebody doesn't have a computer, there's really no easy way to do it whatsoever. It's just, yeah, there's no support. At least it's a little better in Maryland, but DC, and I've been very vocal about it. And especially after they moved the whole process from Department of Health to Department of Alcoholic Beverages, you can get a sense what kind of message that sent to the public. So anyway, and we tried to, at university, we tried to form this group with students going to older adults' houses to help with applications. I'm not kidding. We had one situation where we spent 5 hours doing one application for one of our 85-year-old blind patients who was in such a tremendous pain. We ended up getting it, but it doesn't make any sense, right? The whole process has to be way more simple. I mean, they can get narcotic that will kill them in hours within minutes in a pharmacy. So it's just, anyway, so that's been probably my biggest frustration. Surprisingly, not necessarily working with local assisted living and nursing homes. We can talk about this a bit more later, but that actually hasn't been as painfully difficult. It was more painfully difficult years ago, but it's gotten a lot easier in the last couple of years. But the whole getting a card process in DC only gotten worse since the pandemic, not better. And I think the sort of the benefits and the highlights of my whole entire practice got changed. And interestingly, the whole division practice got changed because now I'm, I don't really actually take external consults anymore because I have a wait list so long that I only take the internal referrals or when Pat sends me a patient or something like that, when just because the sheer volume. But yeah, I mean, we not only nowadays I go to cannabis for management of some symptoms as a first line, not even second, not even third, just first line. Chronic insomnia is a good example where, I don't have any better tools for this. As you can imagine, Medicare theoretically covers cognitive behavioral therapy, theoretically covers non-pharmacological treatments for lots of conditions, but practically it doesn't. And for the entire city of DC, I'm only aware of 2 cognitive behavioral therapists who are skilled in insomnia and take Medicare. So their capacity is so limited. So I really can't send my patients to non-pharmacological treatments. Very few people can afford acupuncture as an example and other really effective methods. But cannabis cost-wise becomes definitely the cheapest, safest, and most effective, I think. So that's been huge change. Same goes for pain. I think nowadays I integrate use of cannabinoids very quickly. And I think the other thing that's changed as more and more colleagues at university have learned what I do, now I get this messages left and right. What's interesting is it also triggered kind of a mudslide of a lot of people getting certified to be able to recommend. I remember I gave the first grand round right after the NAS report in 2017, sometime in, I think, late spring that year. And when I asked, so who's here recommending cannabis, there's only 2 hands, mine and director of our division, Dr. Roth. When I repeated the talk at the end of 2019, we had 13 hands go up out of about 300 internists in the whole practice. So, it's still, what is it, 10% or something, less than that, right? But it's a movement. It's a movement towards the right direction. So there's definitely some uptick gradual. And then the biggest shift, I think, in that is that in our own chronic pain practice, they finally starting to accept this as a viable treatment. So they've created their own internal process in the chronic pain clinic at GW. Even though they still often consent, they will make people sign the contract that will spell out no use of cannabis. And then I would say, wait a second, like, you guys sending me a patient after you made them sign this contract? They say, no, we'll just cross that line off of the contract. I'm like, just remove the whole damn line. Why you still have it there? but every change takes time. So, and I think that the last large category is we serve probably about, at the integrated medicine clinic, not in GW, we have about 20% of all of our 5,000 annual visits be cancer related. So I think that's another large area where cannabis became pretty much, I wouldn't say 100%, but close. For not just for symptoms, there's a lot of interest, as you can of course imagine, for using it for cancer, although I avoided that topic in the book as a plague. I think we all know that the most miraculous cases of cancer we see had cannabis on board, but it's just too controversial yet and hard to discuss. And then my personal interest has always been in dementia. Interestingly enough, just because the Bredesen protocol became so effective, I don't see any role for cannabis at this point, just because our cure rate is somewhere close to 80% at this point. So the patient is able to stick with protocol, everybody gets better, more or less. So the problem is sticking with the protocol. So only 30% can stick with the protocol correctly. So it's not an easy program. But I still want to do some specific clinical research in there, because I think the role of cannabinoids in neurocognitive impairment is going to be huge. Now, I'm not discussing the whole point, not just change or improvement in neurobehavioral problems. Those are standards. So now I usually go to sundowning or any kind of behavioral problems in somebody with advanced Alzheimer's. Cannabis goes pretty quickly. Actually, if it's my patient, it's a first line. But I'm talking about an actual cannabinoids to improve outcomes of a cognitive decline. So I think there's a lot of potential there, although I think exact details of it not very clear, and a whole lot more research is needed. But so, yeah. Dr. Wilson-King, you're muted.
Yes, thank you for that. We'll definitely get into the Bredesen protocol a little bit later. I have a couple of questions about that, but also the fact of trying to get a card is really difficult in Florida as well. You cannot do it without a computer. And I think that happens in other states. So we have to remember that a lot of the seniors don't have computer access. So I definitely agree with you on that. Patricia, you're up.
No, I was just going to, he touched on a number of different things, and I wanted to go back to the assisted living. You said that has been less of a challenge than I suppose in prior years, or in helping seniors with getting a card, particularly in the DMV.
Mhm.
So how have things been going? What's your approach to assisted living? What has there been pushback? What is it that gets you in there and
Right.
help things go smoothly?
Well, I mean, I only have experience of the assisted livings and nursing homes that we affiliate with, and VA. So the VA is a whole separate discussion. There's not a whole lot there because it's just prohibited. And so unfortunately, even though our faculty covers the VA nursing home and VA rehab, there's nothing going on there. But in the rest of the, in the public sector, in terms of the both assisted and nursing homes, the change has been actually pretty positive. Primarily, a couple of years ago, American Doctors Medical Director Associations, which is AMDA, that's the docs who are medical directors of nursing homes. So they actually put out a very positive statement. One of their directors have been very supportive and interested in a topic. So they really basically said, look, if your state where the nursing home is approved medical cannabis, you have a duty for your patients to figure out how to use it. And then they put some guidelines, there has to be safety issues and fire hazard, and they're discouraging people from smoking and things like this, but they're actually quite supportive. So since that happened, we actually have seen, at least for topical, sublingual, and non-inhaled products, there's rarely been an issues in the last couple of years. In fact, quite often I get consults where they would want me to come and recommend something for complex patients, because a lot of the times the patients in the nursing homes unfortunately really have so many symptoms and so not well managed that they're kind of struggling. Like I remember one example, we have this woman who was basically in her last 6 months, and she had a continuous hemorrhoidal bleed, and no surgeon will take her, advanced dementia and on hospice, and she kept bleeding. So I just said, okay, well, I don't know what else to tell you guys. Let's just try highly super concentrated CBD CBDA mix, and it totally took care of it. And so like you start doing things like this, and the next thing you know, you get more consults, and I think the facilities are opening up because they're realizing, wait a second, there's not really a lot of risk for them. I think the original idea or concern was, you're really not allowed to use Schedule I controlled substances if you're getting federal funding. But they're starting to get around this because the statement is, well, my state is allowing, and if the patient wants this, what can I say negative to it? Because in reality, they can simply go to the court and say you have to mandate the use if that's what the patient desires.
Mhm.
So I think it's a combination of just common acceptance plus AMDAs being so supportive, plus I think just the fact that we are in a highly educated area, and a lot of patients are simply pushing. I mean, I can only imagine what's going on in the periphery, and I don't know if anybody want to share something in the chat, but I'm guessing that it's quite still mixed, and some areas are probably very, very resistant. I wonder in Florida, it's probably similar. I mean, I would think it's pretty geriatric friendly state.
It's a very geriatric friendly state, and actually our geriatric population is a major part of the cannabis industry in the state of Florida. So there's, with respect to assisted living, families can provide their loved ones their medicine, and it's not a problem at all. Now, the assisted living facility doesn't give the medicine to the patients, but the family can, it's fine for the family to come in and do it. So that is one thing Florida really is probably doing pretty well on.
Well, that's good. And, I actually see that the future is probably pretty bright, because in reality, there's so many toxic medications that are used. And an interesting part is, I'm not sure if audience aware of this, but nursing homes specifically, they are tracked on performance of prescribing, or rather not prescribing certain medications. So for example, if you in a habit of recommending benzodiazepines or tranquilizers, things like Seroquel or Risperidol, you're actually going to get dinged, and you can get a payment cut if you prescribe too many. So some of the kind of smarter, more educated, more forward-looking directors have actually been looking for cannabis as the way out of using less. And I've heard rumors that few places have such a tremendous success. They're trying to sort of model this to the rest of the country. I actually don't necessarily follow this very closely. My only kind of involvement is I try to go to annual American Geriatric Society meeting, but they've had cannabis covered in some shape or form for the past few years on a regular basis. Probably going to gradually expand, but it's pretty slow. I think in part it's just simply, again, it's a federally prohibited substance, so that creates a certain level of insecurities, I think, in a lot of supervisors of nursing homes. Assisted living is a little different because they don't fall under the same category, so they're not as tightly regulated. And especially more like the ones that are more fancy, Sunrise, for example, there's a lot more freedom that they have, that they can use certain things, but it's still probably heavily mixed.
Yeah, they in this area in Maryland, at least, there's Riderwood and Leisure World, and I see a number of patients from those facilities. Some are in independent living, but some are assisted. And Leisure World actually has a cannabis club. I mean, they are totally organized. They have negotiated discounts at the nearby dispensaries. So they are a very active geriatric population that's really embraced cannabis 100%.
Yeah, I mean, I think I think, as I said, I think the future is very bright, and people see the value, and as we move forward and we learn more and more, I think it's only going to expand utilization further. It does help that this whole opiate deprescribing has been hitting us heavy. I think there's just a lot more opening, so it's a lot easier to talk about with sort of orthopedic surgeons, with chronic pain docs. They're sort of suddenly saying, oh yeah, let's try it, versus before, like, what are you talking about? So
Right.
there's been a major shift in the last, I say, 5 years.
Yeah. At least we're getting more of a consistent response now, as opposed to people just tossing it out the window completely. At least people are now looking and asking questions. So that's definitely progress.
I do want to comment that there was a question about like where to get the link to. The course has the link to the statement, an actual specific statement of the guidelines. So just want to put a plug in there. So.
Right. Yes, he covers that very well in his module. There's a nice checklist for you to use. Now I'd like to get into the Bredesen protocol, which is based on over 3 decades of Dr. Bredesen's lab research. And it's offered in a prevention, a pre-code, meaning prevention of cognitive decline, and recode, reversal of cognitive decline. And the goal is to change the biochemistry to provide optimal conditions for your brain to thrive. And I'd love to hear what you have to say, Dr. Kogan, about your experience in utilizing this protocol. I know you touched on it briefly earlier, but if we could have a little more detail, that'd be great.
Yeah. So I got involved in this way before it was even called Recode, even when Dale was with another company back, a decade ago. So at this point, we treated over 50 patients, and we basically adding roughly about 1 person per month. Our capacity is pretty limited because the program is extremely complicated. Those of you who are interested, you can look up. What you have to do is you have to identify whatever the drivers you can. On average, each person has somewhere between 5 to 10 drivers, and you really have to address all of them. So it's not enough to sort of put everybody on ketogenic diet, make sure they're all moving to ketosis right. A lot of the times people will move into ketosis until night comes and then they ramage the ice cream from the refrigerator. There's just a lot of complexity in the whole process, but you really have to get to the bottom of the drivers. And I've grown over the years very eerie of all the medical approaches, because in reality, I don't even believe Alzheimer's exists as it is. I mean, I think what we're looking at is an endpoint pathology that's meaningless in essence, because it only can help you to say, okay, well, there's a pathology there. As a clinician, I don't really care about pathology. That's for pathology lab, right? For me, I want to understand how did the patient got to the pathology, and there are at least 20 different pathways to get there. So I don't even believe Alzheimer's exists. Say 10% of all the Alzheimer's is just a toxic mercury exposure, 30% toxic mold exposure, 50% is inflammatory states, some of them due to ApoE4, some of them due to some Priscillins genes, some of them due to people eating whatever and living whatever. So there's just so many drivers. The problem comes when the people who did the best are either people who have just a very defined number of drivers and they're easy to handle. So some patients with toxicity do amazing. Like I published the case of I think 89-year-old when I first saw him, and he presented pretty demented. He was a colonel in the CIA, 200 people under him at some point. He basically came in completely unable to function, and gotten on swordfish in Korean War and been eating it twice a week for, I don't know, 10 plus years. So that was pretty straightforward. He's otherwise was completely healthy. We detoxed him from mercury, and like I've never seen anything like this. This was my sort of forte. He basically recovered in 6 months completely. So he came from totally unable to read, write, like still was talking, but to completely fully back aware of everything, reading, fully functional, everything. And then he lived for almost 5 more years until he started having multiple strokes, which anyway, doesn't matter why, but it had nothing to do, well, it actually had to do with mercury probably more than with anything. But so, but those cases in minority, like the mold cases are sometimes, fascinating results if it's just mainly mold. because that's quite workable. But you get patients who have, hormonal shift, toxic shift, sugar shift, they're hyperglycemic, they have vascular problems, they have ApoE4 at the same time. And it gets so complicated that shifting everything, and while, by the way, at the same time, you really have to somehow, it's like 3 or 4 hours a day of different things to do. It just gets so complicated for them that, we gradually shifting. So Dale just is trying to publish the first definitive trial that was IRB approved. They had 25 patients in UC University of California system. And what they did is instead of controlling, because there's no point in controlling, right? We know Alzheimer's is uniformly declinable disease. You don't actually, frankly, need a control in the first trial. So, but what they did, they put everybody on protocol. And in addition to a standard protocol, everybody had a personal coach, multiple coaches. They had a social worker and a coach. So basically, they were in contact with a support system daily, multiple hours per day. So that makes the whole program either crazily expensive, well, actually not either, both crazily expensive and just so sophisticated. And, that's sort of currently, I think, the main roadblock that I see. And then figuring out how to fit cannabis in here, I see most of it more as just part of the package. So, if somebody is very pro-inflamed, should probably try CBD. If they're more of a COX-2 pathway, like they're more osteoarthritic process or rheumatoid, put a lot CBDA. But I've tried back in the day about 5-6 years ago to do different mixes specifically to see what happens with memory. In the early phases, you can see some benefits, but once the certain degree of shift occurs, I haven't seen any miracles, but I do see a lot of improvement of sleep, anxiety. They just suddenly simply more relaxed, and when they're more relaxed, they can just communicate better.
Yeah.
So things like this, I think there's tremendous potential, but I'm mostly really interested. There has to be a benefit of replacing, because we know when patients with Alzheimer's, the FAA drops and, and endamine levels drop, receptor levels drops. Like, we know there has to be some benefit in applying. But the problem is here, the studies have to be very long. I think that's the main problem with Alzheimer's. You can't just do 3 months assessment. It's meaningless. You have to run the studies for many, many months to years. And that creates all kinds of pragmatic problems. Plus, if I'm doing another 10 different interventions, well, how do I even put this all together in a sort of researchable model? That's I don't know. I mean, I think we need to find a couple more big donors to say, screw the standard research process. Who cares, right? If we can take 100 patients and show that, or 1,000 patients and show this level of efficacy, then that's the value. But unfortunately, NIH doesn't think that way.
Yeah, how about that?
We did podcast with Dale through GW. It's going to come out, I think it should come out like either next week or very soon, because it's timed for his new book, for the book that's coming out, that just came out last week. And he talked a lot about this, or sort of the whole incapacity of a standard research model to embrace this, because we're not used to saying, look, 10 interventions at the same time, that's what you're going to get to. That's what will get you to the good place. If you just apply one, nothing will happen. It's sort of mind-boggling for standard researchers. They basically told Dale many years ago, like, look, go away, because we don't care what your results are. You can't tell us what's working. He's like, what do you mean you don't care what the results are? You have millions of people dying from this illness. Don't you want them to benefit? They're like, no, we don't care about that. We really care about answers here. There's a disconnect between kind of standard clinical research and us clinicians in the front of the patient saying, we're going to try to help you. And
right. Yeah, you mentioned that there are many pathways, and one of the pathways you mentioned was hormones. And Dr. Bredesen actually mentions that women experience dementing illnesses at higher rates than men. And he believes it's due to hormonal changes that happen in menopause.
Yeah, I'm convinced of that completely.
Yeah,
I
he
see
basically,
this a lot.
yeah, there's a study that was done, Cache County study, where it was an observational study they looked at over 70,000 plus patients and it spanned from 1995 to 2013, and they were looking at hormone therapy and Alzheimer's, and found that the initiation of the hormone therapy and the duration of the hormone therapy did impact the risk for Alzheimer's, such that if you started hormones within 10 years of menopause and then took hormones for a duration of 10 years, your risk for Alzheimer's was significantly decreased. Late start of hormone therapy didn't affect it at all and actually seemed to increase the risk for Alzheimer's, which is really kind of unusual. There have been studies that actually found similar observations, and a few studies that didn't. But hormones actually regulate beta amyloid accumulation, and they also inhibit the production or enhance the degradation of beta amyloid through some other cell signaling pathways. So hormones really essentially affect the brain to increase neural health and improve and resist Alzheimer's disease and other neurodegenerative diseases. So I think hormones is a big area at which to look when it comes to managing this.
No, absolutely. I mean, it's one of I think there are like 6 large categories. So there's a toxic category, there's an inflammatory category, hyperglycemia, so high sugar category, atrophic, which is low hormones, vascular and trauma. So those are kind of the largest categories. There are probably some subcategories in each, but I would say in atrophic, I mean, the 2 largest categories are thyroid and sex hormones. I mean, there's no question about it and I estimate that among men, the rates are lower, much lower, but among women, it probably close to 50%. So again, the number is going to be, there could be multiple 50% because it's each same person can have 5 different problems at the same time. So, and I'm pretty sure that in upcoming years, as the Apollo Health, that's the Recode, the company that runs the Recode, that they will eventually put out their data, because that's the biggest data collection at this point in terms of total sheer volume. I mean, they have thousands and thousands of patients going through the protocol. The problem is right now, the way it's all structured, we have lots of different practitioners kind of supervising this. And until the level of training and until the level of experience comes up to a certain standard, it's going to be quite difficult. Because I remember in the first few years of doing this, you have to get a certain level of experience to start seeing patterns very quickly. And also, more importantly, have the team. That's what takes the most time, is to create the team that can appropriately support the patients. Because I have seen a lot of times people will get on a protocol, do well for a while, and then life happens, and it all falls apart and it goes downhill. And, that's the crux of it. So Dale, I think, has been working a lot to simplify lots of pieces. Like, for example, in the beginning, patients would have been taking 30, 40 supplements. I mean, that's just ludicrous. It's crazy, right? So now it's a little more organized, more simplified, and it needs to keep getting better and better in that sense. But it's definitely not prime time for wider public. It'll be really interesting to see what happens eventually, because it's pretty clear that this process not only has huge potential, but it's really the only thing that has potential. Like the new FDA approved medication, well, that's criminal. I mean, our university made a decision, we absolutely, under any circumstances, prescribing it to anybody. I mean, we don't want to kill people at some theoretical risk of benefit. We're talking about the new antibody. I don't even want to say the name.
No.
And, so it's pretty clear there's no effective treatments out there. This is really the only treatment that's out there, have some clear level of evidence. And yet the resistance is remarkable. More importantly, once we have more and more data, this will go to CMS, this will go to Medicare, Office of Medicare and Medicaid. And, when I talked to Dale talked to Dean Ornish, probably many of you are familiar with Dean. It took him about 20 years to get his program approved. So when Dale said, well, we finally published first study, and Dean said, oh yeah, it only took you 10 years. That's pretty good. So unfortunately, timeline here is unacceptable for our liking. Those of us who are in trenches and like, oh my God, I gotta help this poor declining patient. But it is painful. I do want to comment a little bit more on hormones. I don't have the late start mark cutoff as long as we clearly seeing enough deficiency levels.
Mhm.
And we may not start patients on hormones right away. We may fix all other drivers first and see what happens, and then only then add hormones. But I think the general protocol says that if you still think that adding hormones on top of the rest of the package will make a benefit, go for it. Even, there is a sense that if you delay it too far out, there may actually be harm. I don't know if there's enough evidence to say either way, I think.
I would completely agree with that. Definitely more evidence is needed. And I saw that someone asked late start. Late start is generally more than 10 years after menopause. That's the definition of a late start.
And most
Patricia?
patients fall in that category when they see us in terms of brain, in terms of neurocognitive impairment.
Yeah.
So what to you when you're starting a geriatric patient with cannabis, what are some of the most important factors that you take into consideration when approaching treatment?
I think the patient's personal experience, that's always a key question. I often have families in the room, so that often drives conversation into really funny places when the grandma would discuss in front of grandkids the history of heavy use in college. I got quite a number of stories. I probably should publish some. So that's the first. If somebody's quite experienced, I often worry less. I usually still go to sublingual full extract oils and start very, very low and gradually titrate up. But I also have some older people come in and they've already been using, and they asking more specific questions. Should I transition from inhaled to sublingual? And so conversation can get a lot more detailed. But most people, they either naive or they really tried so long ago, probably should consider them naive anyway. And so you start just with a couple of milligrams at the most and then gradually titrate up. Usually I start with the nighttime only, just to kind of minimize anything daytime. And then what I often do is to kind of hook them on it. I start tapering off meds rapidly. Like the moment I reach some kind of a target goal of the treatment, we start getting off the meds. Usually one at a time, starting with the most concerning, either opioids or benzos. Usually those two first down. 90% of people will get off the benzos, no matter what the reason for benzos, by the way. If they haven't gotten into trouble, because troubles still occur all the time. I'd say one thing, I tell them, print this, take to dispenser. They forget to print, they show up to dispenser, they get something totally different, they overdose, and it happens all the time, right? So we all know that. But even with the best intention, our level of control here is still, in reality, this much. But most people, if you educate them enough, they get the risk. Generally, I've been seeing risk of wrong things started or wrong doses started has been gradually going down. I think part of it is that I think our area is just getting more experience. Things of, I don't know, we'll see what happens in Virginia. I just started recommending maybe 3 or 4 months ago. I haven't really, I still tell everybody go to DC or Maryland because reciprocity rules apply, because I have no idea what they actually can get in Virginia. So that's another thing, right? I mean, we're also limited to what we can look up and what our patients can have access to. And even if I recommend, say, my favorite CBD products, still most patients probably will need some THC. I mean, I can't get them my favorite online recommendation for that. They still have to go to dispensary.
I find that the most of the tinctures and flowers that have CBD as well as THC are in the district, and luckily Maryland and Virginia patients can go into the district
Yeah.
for those products. There's
Yep.
very little in Maryland.
Mhm.
In your population, Misha, do you see much drug-to-drug interaction issues with using CBD? Because these patients are
Yeah,
unusually
I think
often
you
with.
asked me that before, and theoretically, I think there should be more interactions than in younger population we would think, but honestly, I've only seen one time interaction of opiates with CBD. Not on my prescription. Somebody was just told to the patient, take more and more CBD. Patient got very overdosed, taking a very high dose of CBD. But, you know, with low doses of CBD and THC, not really. I mean, sometimes we get to a therapeutic windows very quickly, and then they still would continue both meds. So they kind of like medication and the cannabinoids. So you may get kind of over treating, same issue, but you know, that's easily manageable. But in terms of interactions, not really. I haven't had. I mean, overdoses occur on a regular basis. You know, people forget to shake the bottle, or they're just miscalculate the dose or something. I mean, but I don't really see that as a.
Mhm.
It's a problem when somebody just starting and then they heavily overdose and then it scares them and then they have this psychological block. That sometimes is hard to get over.
Mhm.
But somebody who's experienced and occasionally overdose, they know, they'll sleep it over and it's okay.
Yeah. I
Interestingly,
have
here's
a,
what I find. I have not found a lot of falls even with overdose versus when they overdose or just take the regular benzos, the falls were happening. I think the reasons for that is you can be high, but you're not disoriented. There is a difference there,
yes,
you
yes.
know, and it's I think it's subtle. Personally, I can't compare. I mean, disclaimer, I mean, I've been high enough on cannabis. I've never been high enough on benzos to understand what's happening there. But the way the patients would often say with the benzos is they get disoriented and unsteady. And I'm yet to
Mhm.
hear that statement with the cannabis overdose. They get disoriented, slow, and careful. So they don't actually fall. Like I'm yet to see somebody come in into the ER saying, I just broke my hip because I smoked cannabis last couple hours. Like I haven't seen a single
Right.
case of that. And it's, you know, I'm seeing thousands of patients a year. So I don't know if that's my bias. It may be. I mean, patients may not tell me things, or I think it's actually real.
Or it may be a theoretical concern due to the, the effect of THC on balance and coordination and time, and reaction time. It's certainly something that I worry a little bit about with older patients,
Right.
but
Right.
again, I have not had that reported back to me either. I was thinking more about the CBD and interacting with things like beta blockers or warfarin or
Yeah.
statins, the kind of medicines that a lot of these patients are on. I haven't really seen it, but I always have them space it. I
Yeah,
just say, don't take the
same here.
CBD for medicine.
That's what I do. But I also try to keep the doses under 100 milligrams and rarely do it orally, always sublingual or topical. So I mean, maybe we're too cautious and we shouldn't worry about any of this. After all, if you look at the Epidiolex studies, I mean, that's thousands of milligrams. I mean,
Yeah.
and you know, they combining it with the seizure meds, for God's sake. Like, you know, can't think of like the worst possible interactions. There's nothing worse than that. And they're
Mhm.
not seeing tons of stuff, even though theoretically there should be massive interactions. So I don't know. I used to be like more vocal that we should really be careful. And now I'm like, I don't know, I'm not seeing it. So why should I be more vocal if I'm not seeing anything? So I think it, in terms of let me put it this way. I have way more interactions to worry about than that one. How about that?
Right.
I have
Okay.
patients coming in on like on gabapentin, you know,
Hmm.
uh, codeine, beta blockers, ACE inhibitor. I mean, like you look at the interaction possibilities and you're like, oh my God. I mean, computer tells me there's like 20 interactions, but like I have no idea. I'm not a computer. I can see, I can figure. So that's the thing. Like there's just so many more important topics that would take priority almost always that I kind of, because I haven't seen anything, I kind of stopped worrying about it. I just keep to the rule of I almost never use more than 100 milligrams of CBD. I use hundreds of milligrams of CBDA. I mean, I had some patients get up to 400 milligrams of CBDA for arthritic processes, and I'm not worried about that. But CBD, I just don't, I also, honestly, I just don't see so much benefit at huge doses that I'm kind of unclear, because you start getting doses up, it costs a lot of money.
And those high doses with the Epidiolex, that's a pretty isolated
Exactly.
product. And so when you're using
Exactly.
a whole plant, full plant,
Yeah,
with the interaction with the terpenes and other
totally.
minor cannabinoids, you really don't see those high
Totally.
doses. Someone
Right.
asked, I mentioned CBDA. Are there any other cannabinoids that you've found helpful? Do you utilize CBG or some of the
Yeah, so
other?
CBG has kind of been my sort of probably the newest discovery. I was hoping it sort of be a really profound for the appetite, because THC for appetite is such a hit and miss. You just never know. I mean, you have one person saying swear about it, but then the other saying absolutely does nothing to me. So, I definitely feel like I felt like CBG is going to fix this, but I'm also seeing the same with CBG. I just can't predict who's going to have a good appetite stimulation and who will not. It probably has more to do with terpenes. I'm not yet at the point where I'm sure some of you here probably know even more than me. So, I mean, feel free to comment. But I definitely see CBG for like more of a depressive symptoms and like upping people, definitely that. And then of course CBN for sleep, but that's not anything new.
Yeah.
THCA, surprisingly, I have not been using enough, I think. I'm not sure why. I haven't really found it to be sort of specifically beneficial for anything in geriatric population to jump on it as a kind of.
I find it as a good
I,
analgesic and you don't get high. So I have a number of patients
Mhm.
using THCA for pain. Mhm.
I also have patients, my elderly patients, look for chemovars with limonene in them because
Mhm.
the studies have shown that limonene is very helpful for depression. And
Right.
a lot of my seniors, experience that. So I have them look for limonene and certain products, maybe even pinene. So
Beta
yeah,
carotene for sure for
broccoli,
pain, for
beta carotene.
sure. Like
Yeah.
that's, in fact, I often would have them get like separate terpenes and then add it in addition to, capsaicin, or just get a chili powder from the Amazon and then mix it in if they're using it topically. I think like
Mhm.
you can, because it's pretty easy, you can simply add it to your existing mix if they're trying to make their own salve. Or just even melt whatever you get from the dispensary, because usually it's either coconut oil, shea butter, or something, but it'll melt at the temperature, and then you can just take that jar and put more active ingredients in there. Yeah, that one I like a lot.
Yeah, yeah. There's another audience question about what is the follow-up structure in your clinic for ongoing guidance and education? I believe they might be talking about, for the patients. Is it just MD visits with you or other prescribing clinicians, or is there a
Right.
whole
So
nother
we
structure?
have naturopath have some knowledge, but not as much. So mostly it's just my own follow-ups at the moment. I'm expecting sooner or later hire a coach because, but if I'm seeing patients through insurance, that's non-viable model because then the coaches are not covered by any existing insurance. Well, definitely not in this topic. So if they're coming to see me through the Medicare or any existing commercial insurance, Medicaid included, then it's just me. So I'll usually see people in the beginning. Once they get a card, I'll see them right after they get a card, like in a week or two, if I can. So it's usually like six to 8 week follow up after I set them up. And then I tell them what to go get. Then they bring that into the clinic, we talk, and then I try to schedule them for anywhere from 4 to 3 months, depending what the issue is and sort of whether I sensing that they're getting it. Some people, some people are really savvy. They figure it out, and then they'll come in, check it once or twice within 3 months, and then after that they don't need to see me all that frequent. But it really depends on the situation. A lot of the times, if it's my own primary care patient, I'll see them anyway. with, with a high frequency. In geriatrics, we tend to see somebody who's over 85 every 3 to 4 months on average, unless they're so doing great and they don't have any medical problems. But usually we don't really see those patients. I mean, most of our patients are, 20 medications, 30 medical problems, home health aid and, all this. So that's a typical clientele. And then we often cover each other. I'm trying to teach some of my colleagues with certain details. The problem is if they don't know some core principle of integrative medicine, I see a lot of mistakes. People don't fully understand that cannabis is just a tool, and they sort of think like, oh, I can just use it as any other drug. And no, you can't. And like, I can't really explain it very well because it requires a certain level of basic understanding of the principle of how nature interacts with the body. And yeah, I can do it with the students. I can do it with some of my junior faculty, but educating somebody who's 20 years my senior and my boss, I'm trying. I grew up not in this infrastructure. I survived shit way worse than this. So like it
It's a delicate
I've learned, but
situation.
yeah, I'm too apolitical to push it on a non-personal above level. So I just kind of try to work with individual colleagues. But a lot of them are getting interested. My own boss at the geriatrics, she gradually over the years, I mean, she just grabs things and learns. I think it helps that we stay open and engaging, and we're not like dismissing people off, right? Saying, oh, you don't know that, goodbye. But I'm telling you, it's a steep slope of learning, and so many people need to learn so much that, and I don't know. I mean, but I'm hopeful. I think in 10, 15 years, when every graduating medical student will have to take some basic training in this, I think they'll come out with some sense what they're doing, But for now, it's unfortunately still hit and miss.
Yeah, very true. Well, it's 3 minutes of the top of the hour. Do we have time for one more, or what would we like to do at this point, ladies?
Well, I see a question. I'm just going to throw the answer out there. It's more of a pediatric question about the use of Epidiolex in high levels. And yes, you can see some abdominal pain and diarrhea that may have to do with the volume, although Epidiolex is highly concentrated, 100 milligrams per ml. But CBD does modulate GI motility. So if they're getting quite a bit, you definitely could see nausea and some diarrhea.
Actually, I want to talk a little bit about this. So I do find that microdosing of THC in enteric-coated form often solves severe chronic constipation in geriatric patients. I don't understand why. We do know that there's some improvement in peristalsis, but the dosing seemed to be off because it can work with 1 milligram TID. And somebody told me that a long time ago, and I started doing this, and they just basically get the oil and put, like, you can buy capsules on Amazon for pennies, and you just drop whatever the dosing into capsule and take it. So it's pretty straightforward. I'm still a little puzzled by this, but constipation in older age is a huge problem, and often it's just completely difficult to manage. And even with all the best integrative methods, magnesium citrate, acupuncture, fibers, sometimes it's just you have to have more and more tools. That's definitely a tool. It mostly happens in patients who have, who has other stuff. Like there's other drivers. It's not the only, like Parkinson's, or there's something else that definitely slows down the motility. But and I haven't used high dose CBD for that. I kind of wonder, maybe that's also something to try, but I've had really good results in some patients. Again, hit and miss. Nothing seems to be, in contrast to insomnia, as an example, right? Insomnia is almost universal. I think we all would agree that, I don't know, 90% response rate, somewhere in that range. With this, I don't know what the response rate, but it's lower, much lower.
But in lower doses of CBD, I've found that if they're constipated, it seems to help rev up peristalsis. And if they're having diarrhea, like if they're inflammatory bowel, and that may be why they're having diarrhea, that it tends to slow it down. So the CBD seems to be somewhat biphasic, and I'm not sure if it's dose related or what.
So there's an actual impact on the peristalsis, or is this more some other? I mean, I actually didn't know that.
Yeah, I don't
Nobody
know. I know
knows. Yeah.
with the Crohn's patients, the diarrhea, the output slows down
Mm-hmm.
dramatically. With
Mm-hmm.
the IBS, with constipation or the otherwise constipated patient, the CBD seems to rev things up. And that's pretty consistent over the years. Mhm.
Well,
All
this has
right.
been absolutely wonderful. Um, I hope everyone's had a good time and learned some things. This has really been very informative and very stimulating conversation. So thank you, Dr. Kogan
Very welcome.
and Dr. Frye and the audience. I'll turn it over to Genesis.
All right,
And I would
everyone.
also like to thank everybody and give Dr. Kogan some love for coming and talking to us today.
Yes. Yeah.
Well, thank you again, everyone, for joining us for today's excellent Canna Talk segment featuring Dr. Kogan and his incredible research insight on cannabis and geriatrics and assisted living. We hope that you guys are enjoying this series just as much as we are. And please be sure to purchase Dr. Kogan's course on cannabis and geriatrics and assisted living directly from the SCC's course curriculum page before the sale ends next Tuesday. So Tuesday is the last day for the sale. Again, it's 15% off for the discount code for non-members, and the code is Dr. Kogan 15, which you guys will see in the chat. We also highly encourage you to join the SCC as a member if you haven't already, so that you can take advantage of our exciting, exclusive membership benefits. We hope you have a great weekend, and we truly appreciate your continued support for the Society of Cannabis Clinicians. Other than that, we look forward to seeing you next month, Thursday, September 23rd, for our next Canna Talk segment featuring the celebrated, world-renowned expert, Dr. Dustin Sulak, and his module highlighting cannabis for health promotion and disease prevention. We'll see you soon. Have a great weekend. Bye-bye.
Bye, everyone.
Goodbye. Thank you.
Thank you. Thank you. Thank you. Thank you.